Hello everyone, welcome to EasyMed. Today we are going to learn about jaundice. Jaundice is related to disorder in bilirubin metabolism. So the idea of bilirubin metabolism is very important for the understanding of jaundice. So if you've not watched our previous video on bilirubin metabolism, please go and watch that video. The topics we will be covering today are brief introduction of jaundice, classification of jaundice, differential diagnosis of jaundice, and some clinical investigations in jaundice. So, what is jaundice? Jaundice is simply the yellowish discoloration of skin, mucous membrane, and sclera, which occurs due to the elevated level of serum bilirubin above 2 mg per deciliter. The normal level of serum bilirubin is 0.3 to 1.2 milligram per deciliter. So, elevation in serum bilirubin above this level will be termed as hyperbilirubinemia. But to be called jaundice, the elevation should be significant enough to cause the yellowish discoloration of skin, mucous membrane, and sclera. And the elevation of serum bilirubin is very important to be called any yellowish discoloration as jaundice, because there's a condition called carotenemia where also there is yellowish discoloration of skin, but it is not due to the elevated level of bilirubin, but is due to the elevated level of beta carotene. So, after knowing this, let's move on to the classification of jaundice. Jaundice can be classified into three types depending on where the pathology affects. These three types are prehepatic jaundice, hepatic jaundice, and posthepatic jaundice. In prehepatic jaundice, there is defect prior to liver metabolism. So, prehepatic jaundice it can be due to different causes which will lead to excessive hemolysis. It can be also sometimes due to absorption of large hematoma, and it can also be due to defect in absorption, or it can be due to the defect in uptake of unconjugated bilirubin by hepatocytes. Prehepatic jaundice will result in unconjugated hyperbilirubinemia. Aber, let's see how. In excessive hemolysis, there is excessive production of bilirubin, but liver has a limited capacity to conjugate it. So, the liver conjugation mechanism will not be able to cope up with that overwhelming amount of bilirubin being produced. This will result in unconjugated hyperbilirubinemia. Now, talking about alteration in uptake of unconjugated bilirubin by hepatocytes caused by drug rifampicin. In this, the liver will not be able to uptake unconjugated bilirubin for conjugation. So, this will also result in unconjugated hyperbilirubinemia. Now, after this, let's move on to hepatocellular jaundice. Hepatocellular jaundice is seen in many diseases which affect liver parenchyma, like hepatitis, alcoholic liver diseases. Not only this, but it also involves many genetic conditions. In hepatitis, there is inflammation of hepatocyte. So, the inflamed hepatocyte will not be able to conjugate bilirubin properly. At the same time, inflamed hepatocyte will swell up and will obstruct the nearby bile canaliculi, hindering the release of conjugated bilirubin into bile canaliculi. So, this will result in both unconjugated as well as conjugated hyperbilirubinemia. Now, talking about different genetic conditions, we can classify them on the basis of whether they cause conjugated hyperbilirubinemia or unconjugated hyperbilirubinemia. The genetic conditions which will cause unconjugated hyperbilirubinemia are Gilbert syndrome and Crigler-Najjar syndrome. In these both syndromes, there is decreased UCT activity, but the difference in them is that Gilbert syndrome is a mild form, whereas Crigler-Najjar is a more severe form. Gilbert syndrome is seen in a large number of population. It is seen in 2 to 7% of total population, and since it is a mild form, it does not produce significant jaundice. But if a person goes under stress, or if a person is fasting, or if a person does heavy exercise, then jaundice may appear. So, the person with Gilbert syndrome will come with repeated episodes of jaundice in which you will see unconjugated hyperbilirubinemia. Now, moving on to the Crigler-Nazar syndrome, there are two types, type 1 and type 2. Type 1 is a more severe form and it is not compatible with life, whereas type 2 is a less severe one and it is comparatively milder form as compared to type 1. Now, the genetic defects which will result in conjugated hyperbilirubinemia are Dubin-Johnson syndrome and Rotor syndrome. In Dubin-Johnson syndrome, there is defect in MRP2 protein. MRP2 protein is a protein which is responsible for the transport of conjugated bilirubin from hepatocyte into bile canaliculi. And in Rotor syndrome also there is defect in a transporter which is required for the transport of conjugated bilirubin into canaliculi. So the only difference which is accessible or which can be found is that in Dubin-Johnson syndrome, the liver, if you take liver biopsy, the liver is black, which is not seen in Rotor syndrome. So in both of the genetic defects, there is built up of conjugated bilirubin in liver. So this excess amount of conjugated bilirubin will regurgitate into blood and it will result in conjugated hyperbilirubinemia. We talked about prehepatic and hepatic jaundice. So now let's talk about posthepatic jaundice. Posthepatic jaundice is caused by posthepatic cholestasis, where there can be obstruction in any level between porta hepatis to ampulla fata. It may be the result of gallstones, which is the most common cause. It might be due to carcinoma of pancreas or carcinoma of ampulla fata or tumors of bile duct or biliary strictures. Sometimes chronic pancreatitis may also result in posthepatic jaundice. The characteristic feature of patient in posthepatic jaundice is pale stool and dark urine. Posthepatic jaundice will result in conjugated hyperbilirubinemia because in posthepatic or obstructive jaundice there is obstruction of bile flow. So the conjugated bilirubin will build up in liver and then will regurgitate in blood, resulting in conjugated hyperbilirubinemia. Now, why will patient in posthepatic jaundice show pale stool and dark urine? In patient with posthepatic jaundice, there is obstruction of bile flow, so the conjugated bilirubin will not reach the intestine to be converted to urobilinogen and then to stercobilin. So the lack of stercobilin will give the pale color to the feces. And as we know, posthepatic jaundice will result in conjugated hyperbilirubinemia. And as we know, conjugated bilirubin is water soluble. So it can pass the glomerular capillaries and be seen in urine. So it will be excreted in urine, giving dark color to it. We know that jaundice is a sign. So, if a patient comes with jaundice, it is very, very important as a physician or as a doctor to know about the underlying cause of it to treat it. So, what are the different tests which can be done to make out differential diagnosis of jaundice? These tests are serum bilirubin, which includes total bilirubin, indirect and direct bilirubin, urine urobilinogen, urine bilirubin, and also liver function test like alkaline phosphate, gamma GT, and aspartate transaminase, and alanine transaminase. Now let's talk about clinical approach to jaundice. A patient will come to you with clinical jaundice. Now, how will you lead the case? How will you make the diagnosis? So, You can start with serum bilirubin test. With total, indirect, and direct serum bilirubin, you can find out whether the person is having unconjugated hyperbilirubinemia or conjugated hyperbilirubinemia. If the person is having unconjugated hyperbilirubinemia, you can see for signs of hemolysis. If the person is having signs of hemolysis, like increased reticulocyte count or decreased hemoglobin count, then the person is having hemolytic jaundice. But if the person do not have those signs of hemolysis, then you can suspect genetic conditions like Gilbert's syndrome or Crigler-Nazar syndrome. If the person is having conjugated hyperbilirubinemia, then you can go for liver function test. In liver function test, if there is significant increase in ALT and AST, then this is of hepatocellular origin. So this jaundice is hepatocellular jaundice. And if there is elevation of alkaline phosphate and gamma GT, then this is indicative of biliary obstruction. So this is posthepatic jaundice. And if there is no elevation in liver enzymes, then you can suspect Dubin-Johnson syndrome or Rotor syndrome. So this was all about jaundice. Thank you for watching this video. If you have any questions, leave your questions in comment section below. And if you found this video helpful, don't forget to like, share and subscribe.